got it.
All right. So welcome to everyone who's here. There may be more that join us shortly, but welcome to the Innovations in Community Care. It's a 10-week series of brief TED-style talks on important topics in community medicine. Tonight is the fifth in our series. My name is Dr. Lawrence LeBeau. I'm Program Director for the Wright Center for Graduate Medical Education, National Family Medicine Residency Program that organized this event. The speakers you'll hear from each week are faculty members from one of our training sites. And if you've been with us before, you know that I always say one of our training sites because our program is the only national consortium of teaching health centers that have come together to form one ACGME accredited family medicine residency program with osteopathic recognition that operates as a single program with training locations in 4 different states. Our community health center partners are El Rio Health in Tucson, Arizona, HealthSource of Ohio in Hillsboro, Ohio, HealthPoint in Auburn, Washington, and Unity Healthcare in Washington, D.C. If you're a student joining us tonight and you're considering applying for family medicine residency, we'd love to meet you afterwards and answer any questions that you have about our program. Faculty and others are welcome to stay and ask questions about our program as well. Tonight we have some faculty and we might even have some residents from our program by the time we're finished who will join us and be available after this talk to take your questions and answers about that. But in the meantime, we know that everyone's time is valuable, and we want to keep each talk in this series both high value as well as brief and to the point. The presentation should last about 20 minutes, followed by plenty of time for questions and answers. And with that brief introduction, I'm going to hand things over to Dr. Will Dixon and Dr. Catherine Njiru-Sewer from our Unity Healthcare Community Health Center partner site in Washington, D.C., for their presentation tonight on asylum evaluations. Take it away.
Great. Thank you so much, Larry. So as Dr. LeBeau said, I help, we're in Washington, D.C. I help run the Wright Center campus here. And today, Catherine and I are going to talk a little bit about asylum evaluations. And so both Catherine and I participate in doing evaluations for people who are seeking asylum. And we'll start with Catherine sort of talking through a little bit about just what exactly asylum is, and eventually we'll transition back to me, and I'll go over a few cases and a little bit about what the physician role is in asylum seeking. Catherine, you're muted.
All right, sorry about that. Thank you so much and welcome to this talk. Like I said, my name is Catherine Njiru-Sewer. I am a graduate of the Wright Center program. So, and I am privileged to give this talk to you guys today. So brief introduction from basically from the United Nations High Commissioner for Refugees. They define forced displacement as displaced as a result of persecution, conflict, generalized violence, or human rights violations. That's what is made up of who a refugee is. There are 2 distinct types of forced displacements that they go through, and that is conflict-induced, for example, if they have a military coup or civil war, or disaster-induced if they have like an earthquake, like if you recall the Haiti earthquake back a few years ago, there was a disaster-induced refugee migration. Okay, next. So before we move on, we need to kind of take a step back and look at some startling statistics that as of December 2020, there were 80 million forcibly displaced people worldwide. Out of those, 45.7 million were internally displaced people, and we'll talk more about what that means. And then 4.2 million were asylum seekers as of mid-2020. And then 26.3 million are refugees. And we will delineate the difference between the 2 later on in the presentation. And then 3.6 are Venezuelans displaced abroad. So that's pretty startling when you look at the grand scheme of things and how many people are going through a lot of distress and a lot of trauma and persecution in the world. Next. So if we take a step back, who are the forcibly displaced? Like we saw that statistic map, there are internally displaced persons. These are IDPs, basically people who are forced to flee their home, but who remain within their country's borders. That is, they don't cross international borders. The difference is that they are not, the international laws do not protect them. So they are under the mercy of the laws of the country where they are. And then you have refugees, someone who's forced to flee their country because of war, violence, or persecution. And to qualify as a refugee, you must have a well-founded fear of persecution. For example, the Rwanda genocide, they had a well-founded fear of being murdered by an ethnic group that was not their ethnic group. So that's something to look at in terms of refugees. And then you have the asylum seekers, someone who flees their country to seek protection in another country. So they come from a different country and they come to the US and they're seeking protection. And in order to receive that protection, they must demonstrate that the fear of persecution in their home country is well-founded. Next. Right. So some immigration 101 pointers. For legal immigration into the US, you have a few options. You have non-immigrant visas, such as student visas. This is one of the visas I came with when I came to the US. You also have employment-based visas, for example, H-1B, family-based visas, for example, applying for immediate family members. And then you have the humanitarian, which is the asylum visa. So you can also have the T visa, which is given to those who are trafficked into the US, or the U visa if they undergo a lot of persecution, mental, physical abuse while they're here in the US, they're given that visa. For example, if they are persecuted or were mistreated by cartel. And then you have Daca. You've heard about this controversial thing in the news, but these are the immigrants who came to the US when under 16, or they were under 31 on June 15th, 2012. They've resided in US since June 15th, 2007. So as you can see, there are different stipulations that qualify a DACA immigrant holder or immigrant seeker. Next. So a legal definition of asylum. So pretty much like I said before, the asylum process is the counterpart of the refugee process. For those who seek refugee status but are already on US soil. So a refugee may be somebody who's not on US soil, but an asylum seeker is one who's already on US soil. And they have this definition according to the Immigration and Nationality Act, that it's any person who is outside any country of such person's nationality. And as you can see, who's unable or unwilling to return to protection of that country because of persecution or a well-founded fear of persecution on account of race, religion, nationality, and so forth. So this is what we call the legal definition of asylum. So filing for asylum, you must file within 1 year of last arrival in the US. But there are some exceptions, and those are changed circumstances that materially affect eligibility. You can have extraordinary circumstances related to delay in filing. For example, serious illness or disability, a legal disability, such as an unaccompanied minor, ineffective assistance of counsel, which can happen during these proceedings of seeking asylum. And mental health experts are very crucial in cases, especially where PTSD or other mental health issues may justify waiving the bar to file the asylum in 1 year. So now we can delve into a little bit about the role of the physician asylum evaluation and asylum claims. So in order to provide unbiased documentation of evidence of torture, maltreatment, and effectively communicate such evidence to adjudicators, the physician must conduct a comprehensive interview. You must elicit a thorough history of the alleged torture and related traumatic events. You must describe the consistency between the exam findings and specific allegations using knowledge of torture methods and their common after effects. You're going to see that Dr. Dixon will demonstrate that later down the presentation. And then you must render expert interpretations of the findings in medical legal examinations and provide an expert opinion regarding findings and sequelae. So you must also be a licensed clinician and should have training in the documentation of forensic documentation of torture and other forms of physical or psychological abuse. So we took a training, like I took a training from the Physician for Human Rights, and that's how I was able to participate in these asylum evaluations. Next. So also, in order to perform these evaluations, you have to provide trauma-informed care. It's really crucial to use this approach because it considers the pervasive nature of trauma, and it promotes environments of healing and recovery. And the way it does this is by realizing the widespread impact of trauma. You have to understand the parts of recovery, since these asylees have gone through really devastating scenarios. So you have to really understand that impact to their mental and physical well-being. You have to recognize the signs and symptoms of trauma in patients, families, and staff. Also realizing that you yourself will have what we call vicarious trauma. Sometimes you may listen to these stories and really internalize that story, and just being mindful about that and taking care of yourself as well when you're dealing with these issues. And integrating knowledge about trauma into policies, procedures, and practices in the clinic that you're performing these trauma-informed care. And then you want to actively avoid re-traumatization. Next. So how can we prevent re-traumatization? As primary care physicians, we can prevent it by advocating for safe and inclusive environments, including within our own clinic. You want to encourage hiring providers and clinic staff who also reflect the community being served, which creates a very inclusive environment. So having a diverse staff will help. Acknowledging the steps the family or youth have taken in entering a new and unfamiliar system. It's a really big change to come from a different country to the US. It's quite a culture shock, and then they've gone through a lot of trauma. So you also want to seek help from colleagues. Teamwork is really crucial here in terms of social workers, patient advocates, support groups to help families navigate the new system. And then lastly, understanding and respecting culture, societal norms, and or religious beliefs. This is really good to help build rapport and trust, because various things you do may offend somebody. For example, a female asylee seeker may prefer to be examined by a female. So it's really crucial to understand those societal norms when you're dealing with this population. Next. So in terms of documenting physical findings, that's also another physician role. You need to follow a systematic approach. And basically you want to interview, you want to elicit past medical and social history, details of the persecution. You also may use interpreters. Also just let the asylee know that you are going to use an interpreter, because they might wonder who's that on the other line or who's that on the Zoom call. So you always want to prepare the person that you're going to be interviewing that this is going to happen. And then you want psychological assessment. You want to evaluate the burden of mental distress. You can use tools such as the PHQ-2, PHQ-9, and there's also a refugee health screener, which is RHS-15, and it really looks at mental and how the trauma related to what they've gone through. So it's a really good screen to have, and it's available online. And for physical assessment, you want to examine the scars, injuries, and other physical findings. For documentation, you write detailed report assessing consistency of findings with reported physical trauma. And then lastly, you want to teach the asylum adjudicators on the psychological and physical impact of trauma and or maltreatment. So it's your role to make sure that that documentation teaches a thing or two about the sequela of this psychological and physical impact of trauma. Next. All right, and just like we talked about some of the resources, there are the Istanbul Protocol, which is very good in kind of giving you an idea of how to document the physical findings. We have the training from the Physicians for Human Rights. There's a book called Examining, it's a clinician's guide, and I have that here. You can purchase it from their website. on how to examine asylum seekers. You also can use the Cornell Asylum Evaluation Training Manual and also peer templates for exams. So that's where your teamwork comes into play. You can ask some of your peers if they have templates that they can use, that you can borrow from, or, you know, not exactly copy, but something if you really need to know how to document, that's also a good resource.
All right,
All right,
thanks so much, Catherine. So I'm going to take over and talk for a little bit here. I wanted to start off with a brief content warning. So I'm going to be going through a number of different examples from asylum cases that I've seen and talking through a little bit about what you know, what goes into the exam component of it. And many of these people have undergone like pretty awful forms of torture or other physical violence, and so we are going to be engaging with some of that stuff. And so I want to make sure that people are have that content warning ahead of time. This portion will also be somewhat interactive. And so I may be, for each of these, I'm going to be asking the group if they can sort of figure out where it came from. Because, you know, one component of doing asylum evaluations is you're sort of a detective in some ways. You know, the patient's physical scars tell a story. And your role, the court, is like looking for you to see if the physical story told by the patient's body matches up with the story that they have told in seeking asylum. And there's sort of a hierarchy of evidence that we'll sort of go over now. The lowest hierarchy would be that their, you know, physical exam is not consistent with their physical findings. If they were alleging, you know, being hacked by machetes, but were not bearing scars, or if they had scars that appeared from different things, you would say that it's not consistent. But there are sort of, as things appear more and more consistent, we'll sort of go over through each of these cases what you would say. So starting off with this one here. So this is a lower extremity wound, about 3 centimeters long. Does anyone have a sense of what sort of wound would cause this? You can put it in the chat, and you can feel free to speak up if you're brave. An abrasion. So this one is actually, it's a laceration, and so it's some of the clues to this, or it's perfectly parallel with the tibia right there. And so this is what happens when a sort of a blunt object is taken and strikes someone over exactly, yes, like a blunt object like strikes over a bony surface. So there's not too much skin overlying it, and it will split open into a laceration like that. In this case, this person then let it was not able to get stitches in order to have it heal. And so it sort of healed by secondary attention and filled into that like sort of oval looking shape right there. And so that was this patient's story. He was detained and he was beat with sort of clubs and sticks across his lower extremities, and it caused a number of abrasions, this being one of the biggest ones. And so this is an excerpt from my affidavit where I said that it's consistent with a laceration, which was healed by secondary intention. So I thought that in this case it was consistent. And what I'm saying there is it matches with this story. It could possibly have been caused by something else, but it is consistent with what he was saying. How about this right here? What do you think this sort of pattern of scars would come from? Yeah, sharp injury. That's good. So this is specifically, and you can sort of see these 2 long straight incisions with the sutures right here, and then a couple further scars right there, stab in the ribs. Yeah. So what this is the remnants of a thoracotomy procedure. So this is after he was stabbed in the chest and had to be rushed to the hospital and receive a thoracotomy there in order to stop the internal bleeding. And so in this case, I said it was highly consistent with that story. So highly consistent is sort of the next level hierarchy of evidence above consistent. There's not too many other things that that could cause this. All right, for this next one here, this might be a little bit hard to appreciate. Are you guys able to see my cursor? Is it? You can see my cursor.
Yes, we can see the cursor.
Great. Sorry, I've been fidgeting with it, so I hope it hasn't been too distracting. So here you can see one scar here that is lined up, and it's a little hard to appreciate, but there's a second scar right here. So what do we think this could be from? Again, scar here, scar here. Grabbing a knife by the blade. Interesting. There's maybe one. Yeah. So this is a very good critique. This is a very classic defensive scar. So this is someone who was in detention and held his hand up like this to block a blow coming down with a club. And you can see. Whoops. I'm giving away the next one. So you can see that there's a scar that ran across his hand and then down across his brow here too. So this is another sort of highly consistent. It's pretty hard to to get this sort of pattern of scars, except for sustaining like a defensive wound like that. So this is another one of these things that lends a lot of credence to someone's claim of assault. How about this next one here? So this might be slightly hard to appreciate on the opposite finger, but there's a scar that runs across like this. And then it's a little hard to see, but there's actually like a little scar on this finger too. What do we think this one would be? It's funny because if I didn't know Katerina said grabbing a knife by the blade for the last one, I would think that she had guessed it and guessed correctly for this one. So this is a defensive wound that's caused by someone grabbing a single-edged kitchen blade. So he ended up with scars only on one side of the hand, grabbed the blade like this, then it was pulled out to try to stop someone from stabbing him, and then it was pulled out of his grasp. And so that created this laceration here that cuts across this finger and then goes into the other one. Again, highly consistent. It's pretty hard to get a scar like that, except for like a cut like that. And there's not a corresponding cut to his palm. So his explaining that it was a single-edged kitchen blade makes it pretty makes it, in my view, that sort of highly consistent hierarchy of evidence. How about this one? So we're looking at a forearm here. This is a big sort of arcing, curved scar right here. What do we think this big curved scar would come from? Yeah, so this one's from an assault. And there's like a very particular sort of assault that tends to cause these. And what that is this is someone who is hit with a machete. And if you think about if you have a round surface, if a strike comes down perfectly perpendicular to that round surface, the scar will be straight. But a round surface that's struck at any sort of angle is going to create a curved scar like this as the blade, a straight blade enters here for the rounded part, but then curves to the side as it goes in. So this one again is highly consistent with the being struck by a machete blade, which was this person's account of their assault in their the country that they fled from. So this right here is a plain film. What do we see in this plain film? Very good. Yeah. So this is, Katerina says, a buckshot. And so there are tiny little hyperlucent areas that we're seeing all over there. And so that's metal that's in the side. And there's a particular aspect of this that really tells the story, that lets us know that it's buckshot. And I guess it would be fairly hard to get stuff in, but is there any, and this is a little bit of read my mind, but what other clue do we see from this, that this is a sort of a unique unidirectional, like that all of these got in coming from the same direction? So again, I'm looking for you to read my mind here, but the answer is that they're all there's none in the back. So you can see this one right here is like it has not penetrated the skull. These right here are ending up in front of the jawbones there. There are some on the side, but these are actually trapped in the sort of the side of the scalp, and we don't see anything to the back of the scalp right here. We don't see anything in the back of the neck. We don't see anything going down the patient's back right there. So this is someone who in Tahrir Square actually was shot by a member of the Egyptian security services with a probably bird shot. So it's a sort of small pellet munition. So it didn't kill him, but it ended up with having these pellets sort of strewn all throughout his body, including this one, which blinded him in his eye. Oh, and sorry, and part of the point of this is this one reaches that next hierarchy of evidence in it, whereas I described it as pathognomonic. There's really no other way that you can have these sort of physical findings except but by being shot with buckshot. And so that's that final level of evidence that it's sort of no other possible way that you could have gotten in. So even above highly consistent, it's pathognomonic for having been shot with a shotgun. All right, and finally, how about this scar right here? I wouldn't be surprised if a few of you guys have seen a scar like this. What do we think this is? A bite? Okay, good guess. Any others? Burn. It does look a little bit like a cigarette burn. So this one I decided to introduce for a little bit of levity. This is actually a BCG vaccine. And so it's someone who has had a tuberculosis shot on his arm right here. And I included a little bit just to tease the assembled crowd. But also this scars like this are actually fairly useful for asylum cases, believe it or not. So when a client has scars that are, they say, no, this, I fell on playing soccer. That's how I got this one, or I scraped myself on a bench when I was a kid. This isn't from it. I'm actually really careful to document that and include them with the affidavit. And then in the final part, and sorry, this is a little bit of a wall of text, but I usually say in this final bolded part that the client is not attributing every single scar on his body to the beatings, and I find that lends credence to the veracity of his claims. And so when there's a series of scars that are not actually coming from the assaults that they have suffered from, and they're not attributing every single scar on their body, I think that's one further thing that helps to lend credence to the scars that they are attributing to assault. So that's a little bit about what it actually looks like to be providing care for asylum seekers. Here are references here. And so, this is doing asylum evaluations is something that Catherine and I have sort of taken on as part of being a community medicine doctor in DC. We take care of folks that are from all over the world, many of whom are asylum seekers. And so in part of being a good community healthcare doctor, we have sort of seen that as doing asylum evaluations. So thanks so much for everyone for attending, and who has questions that we can answer? You can feel free to put it in the chat, or I think that there was one back above when Catherine was speaking that I missed. So Pratik says, yeah, sorry, do you want to say that last?
No, you can go ahead.
Okay. Pratik said, psychological trauma doesn't need documentation. Yeah. Do you want to feel that one, Catherine?
Yes, it does. Thanks for that question. Yeah, like I was mentioning earlier, we do a lot of team-based approach to this evaluation. There is also a psychological evaluation. We have like a psychologist or psychiatrist that is involved in evaluating the patient to quantify and solidify that they have gone through some PTSD or some mental health sequela. So that is definitely part of the documentation that goes into it.
Yeah, and so I usually end up doing taking them through the different criteria for PTSD and including that in my evaluation for support for their affidavit. The attorneys often have decided to often try to go get a psychologist to weigh in as well. That's a good question. What other questions do you guys have? And these can be questions about the asylum evaluations or about our wonderful residency program if you're interested in that.
And Dr. Dixon, there's one, are you ever expected to testify in person, such as in a deposition or in a trial?
Great question. Yes, so not always, but often you'll be asked to come up and talk about your case. I actually haven't. There was one time where I was asked to come to talk in trial, but we couldn't make it work out due to my clinic schedule, and it ended up being okay without it. And this is a good question. How does a person come to you? There's such an enormous backlog of people who need evaluations that if you express even the faintest amount of interest in within hearing distance of any person who would want to do evaluations, then they just sort of come pouring in. You'll have more than you can ever hope to field, and so you have to sort of pace yourself. And so basically I did the training. After that training, I was on an email list for Physicians for Human Rights, and so I get emails all the time asking me to do these. And it's it's definitely one of the things that I feel really good about doing. Like, there's no more deserving people than these poor folks that I do evaluations for. They're extremely time consuming, and so it's a little bit hard to do as many as I would like to, I'll admit. So I try to pace myself to do one every couple months or so. Katerina asks, what sort of licensure and certification is needed? Do you want to field that one, Catherine?
Yeah, sure. So there are ways of doing so obviously we have the DO license or MD license, being a physician, but you can get a certification through the Physician for Human Rights. They have a training that they do actually virtual training as well. They do them based out of New York. So that's how I was able to get my certification of training. So it's called Physician for Human Rights. And on their website, they have dates of when they offer the training. Yeah,
and so I also attended a training by PHR, and so going through that training is, when I'm writing out my credentials, I say I'm an attending physician, et cetera, and I have undergone training in asylum and sequelae of torture through Physicians for Human Rights. So that's all the certification that I put. And generally, so I'm an attending here in DC, and so I check to see, usually periodically, I check to see if any residents are interested in doing it with me too. And so, Catherine, for example, came along to sort of shadow at first, and then write more and more of the evaluations as we to prepare her to go off and do them. Pratik asks, what if you feel like asking for a second opinion? How might you manage that? So Pratik, are you sort of saying, like, if there's a scar where you're not totally sure whether it's like I think that's the question is, like, okay, great. So if there's like a scar where you're like, I'm not totally sure where that came from, I'm not sure if it's consistent or not. I think I would probably write that I'm not sure. I might write that it's if I thought it was the scar was consistent, or if it was just something that I was unfamiliar with, like a weapon or something like that I wasn't familiar with, I might tell the lawyer that, hey, this is something that I'm not 100% sure on. I'll document that, but it might be worth you finding another physician who could weigh on this particular thing. You can also, it's one of the things where it's great to have more and more people practicing together, because just like any other condition that you come across and you're not totally sure how to deal with, like, it's always great to have awesome colleagues that you can pull in and ask about things you're not sure on.
Hi there, my name's Marissa.
Hey, Marissa.
I'm a fourth year student at AT Still University, and I just had a question regarding, so once they're being evaluated for asylum, do they often get connected up with the community health center and find like a PCP and all that? How does that kind of play out usually?
Yeah, great question. And so like, honestly, like often this is sort of happening like outside of my Unity job. It's like something I do as volunteer work. I often am doing it in Unity facilities, like sort of in my free time, but very often something comes up where you're like, yeah, you should be seeing a doctor about that. And so I usually then sort of once the exam is concluded, walk them through how they can go downstairs and make an appointment to establish with the primary care doctor. But it's definitely an advantage to working where we do. Which ATSU site are you in?
I'm actually based in the Hawaii site,
Yeah,
but
cool.
I'm originally from Seattle in the Pacific Northwest. So
Awesome, great. We've got a program there.
yep.
And just word of advice for the medical students while you're, trying to get into this, always get a mentor. I have a shameless plug for Dr. Dixon. He really guided me through this process, and I'm still hoping to do a few more before I really get comfortable to do them on my own. But he was really integral in planting this passion and igniting it. So always get a mentor that shares that passion and run with it.
Yeah, and in general, going to, if you end up at a community health center, there will probably be folks there who are interested in doing asylum care, and sort of asking around to, you'll find someone, or, when you go to one of those PHR trainings, like you can often ask, like, I'm not totally sure I want to do one on my own right away. Can you try to, is there someone around? And that's how I found my mentor way back when. What other schools are you guys from? Hey, Lake Erie, that's great. We have at least one resident who's come from Lake Erie. Awesome. If you guys have any questions at all about our programs too, we're sort of an unusual format for a residency. If you have any questions about that, we're happy to answer them too. Catherine is a recently graduated chief resident. So Catherine was the chief resident of the DC program up until last year. So that's great. Pratik is from India. Wonderful. All right. Okay, folks. If there's no other questions, we can let you guys go about your night. Thanks so much for coming out and for your interest in our program.
And just as a reminder, all of these sessions are recorded and they'll be available for viewing afterwards on the Wright Center for Community Health YouTube channel. The link was just put in the chat box for you if you need that. Yeah. So thank you everyone for joining us tonight. Enjoy the rest of your evening.
Take care, folks. Nice work.